Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Hi everyone, and welcome to the first webinar organized under Asia Pacific Glaucoma Society's Young Glaucoma Experts program. My name is Virna Dwi Oktariana Asrory, and I am your moderator for today's APGS activity. The Society endeavors to foster an environment where our junior colleagues can benefit from the expertise and experience of the professors invited to participate as mentors. This is meant to help develop and assist with your clinical research and clinical practice. Before we started, I'd like to go over a few items. APGS welcomes everyone to become a member of the society. It is open to glaucoma specialists, ophthalmologists, researchers, trainees, specialists, associates, and companies with affiliation of glaucoma. There are many reasons to join APGS, and on screen are just a few items which we can share with you. You can register as a member by scanning the QR code. All APGS members gain access to all recordings of the previous APGS joint symposiums, master classes, and webinars. We have many webinars and symposiums previously. One final disclaimer, presentations are intended for educational purposes and do not replace independent professional judgment. After the conclusion of the event, you will receive a short feedback survey, and we would really appreciate it if you could take a moment to complete it. I'd like to begin with the webinar proper by thanking our mentors today, Professor Kessara Pathanapitoon and Associate Professor Shamira Perera. Our first mentor is Professor Kessara Pathanapitoon, is a professor at Chiang Mai University, Department of Ophthalmology. She obtained her medical degree from Chulalongkorn University in Thailand. She completed her fellowship in glaucoma and uveitis at the University of British Columbia in Canada. She also holds a doctorate PhD in uveitis from Utrecht University in the Netherlands. Professor Pathanapitoon is the immediate past president of Thai Ocular Immunology and Inflammation Society and is a member of International Uveitis Study Group. Her research interests focus on glaucoma and uveitis. Our second mentor is Associate Professor Shamira Perera, is a senior consultant ophthalmologist and clinical director for complex anterior segment surgery in Singapore National Eye Center. At SERI, he is the co-head of bioengineering and devices. One of his patients is teaching and is the current program director for SNEC residency. As the deputy director of the MedTech office for SingHealth, he has distributed about more than $6 million for innovation, supported by $4 million Singapore of competitive research grants SPI. His core work has yielded 8 patents, 90 invited lectureships, 5 book chapters, and more than 150 peer-reviewed publications. And now, let me introduce the presenter for our first case presentation. I am pleased to introduce our first young glaucoma expert case presenter, Dr. Yulinda Laksmita, currently works as a clinical and teaching staff faculty member at the Faculty of Medicine, University of Indonesia, Dr. Cipto Mangunkusumo Hospital. She completed her medical and ophthalmology education at the University of Indonesia and accomplished her glaucoma fellowship education at the same institution. She takes part in several ophthalmologist organizations, including Indonesian Ophthalmology Collegium, Indonesian Ophthalmologist Association, Indonesian Glaucoma Society, as well as editorial board of Perdami Young Ophthalmologist Share newsletter. And I now give the floor to Dr. Laksmita. Please, Dr. Laksmita.
Good evening, everyone. Assalamualaikum. I would like to thank Dr. Dotan and the APGS board for giving me this precious opportunity to present cases A woman 45 years old came to our emergency room with complaint of sudden blurred vision, she said, since 8 hours prior to admission. She felt a mild pain on both eyes with a mild headache. However, no eye redness noticed, no nausea, and no vomiting. There are also no trauma to the eye beforehand. Patient said that this is the first time she experienced such condition and she had never undergone any eye surgery before. She had diabetes diagnosed since 2 years ago, and the blood glucose is still uncontrolled. The visual acuity of the right eye at the ER was 1 meter finger counting with no improvement with pinhole. The IOP was 50. The central cornea was edema. The anterior chamber was deep with no cells nor flare visible at that time, and the enlargement of the gap was noticeable with the ratio of 0.7. On the left eye, apparently the visual acuity was already a no light perception with the IOP of 51. Also, edema on the central cornea was noticed, and the cap to this ratio was 0.8, 0.9. Patient also had some skin ulcers due to her poor diabetic control. Some differential diagnosis came in mind. Honestly, my first thought was a neovascular glaucoma, and I expect to find a new vessels on the angle gonioscopically and find a proliferative diabetic retinopathy after dilating the pupil. The patient got the oral acetazolamide 3 times 1 tablet with the potassium aspartate, timolol eye drops for both eyes, and also latanoprost only on the right eye. 7 hours later, after treatment was administered, the visual acuity on the right eye was significantly improved to 6/40 with pinhole. The IOP was also improved to 19, and we finally able to perform gonioscopy, and we found that the angle was wide open, no new vessels found. The pigmentation was also normal, and no precipitates are visible on the angle. We did pupil dilation and found no findings related to a diabetic retinopathy nor posterior uveitis. For the left eye, as expected, the visual acuity is still no light perception with significantly decreased IOP to 16. However, we found a punctured epithelial defect on the cornea stained with fluorescein. We saw the patient for 2 consecutive days. The visual acuity of the right eye was getting better and stable at 6/30. The IOP was still improving from 19 on the first day, 15 on the second day, and 9 on the third day. The left eye, the IOP was also controlled 17 and 13 on the third day. However, we found the keratitis on the cornea and also cells and hypopyon in the anterior chamber. Due to the remarkable improvement of the IOP, the acetazolamide was then stopped. A week after patient came for follow-up, the IOP of the right eye was good, 16 with the use of 2 eye drops only. On the worst eye, the left eye, the IOP was also good, which was 7 only with 1 drops, which is the beta blocker. The corneal keratitis has become a corneal scar with no epithelial defect found. AC inflammation has already diminished. The optic nerve OCT on the right eye showed thinning of the arena file, especially at the superior and inferior quadrant. The Humphrey test showed an advanced glaucomatous visual field defect. My first thought of diagnosis, the neovascular glaucoma, was excluded because of no findings of new vessel on the iris and the angle. There is also no proof that lead to an uveitic glaucoma, even though there is a suspicion of an abrupt high IOP. However, considering that the patient is in a immunocompromised state, proven by some diabetic ulcers that she had and also a keratitis on the left eye, I'm thinking whether she is also prone to infection that leads to uveitis such as a viral infection. And lastly, this might be simply a primary open angle glaucoma. So for now, we decided to observe the patient and continue the glaucoma medication as long as needed. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Laksmita. And now I invited Professor Kessara and Professor Shamira to have their insight about this topic, please.
Hi. Hello, everyone, and thank you very much, Dr. Yulinda, for a very interesting case, and your presentation are excellent. This case was a very nice example of the young lady presented with the bilateral acute elevation of intercalated pressure with open angle, which are underlying of diabetes that poorly controlled, and probably that she might have the poor compliance, though we don't know her hemoglobin A1C level, but we can assume that she already developed the vascular compromise shown by the gangrene at her finger and the uremic stage. And first, I would like to discuss about the diagnosis of this case and the different diagnoses. I agree with you that first we should think about the neovascular glaucoma because she has the underlying of diabetes. However, NVI was absent, the angle was open, and there were no peripheral diabetic retinopathy, and the CRVO shown in the retina. So we may rule out the neovascular glaucoma. It is unlikely that the pre-rubeotic stage of the NVG will give such a high intercalated pressure. And the second cause that you think about is uveitis. Yes, you may think about the herpetic-induced tuberculosis with the Posner-Schwarzman-like presentation, but it is quite uncommon to affect both eyes simultaneously. And her cup-disc ratio is quite advanced damage in. It is indicated that the intercalated pressure elevated for quite a period of time, or the chronic rise of the intercalated pressure. However, just for us to know that the association between the anterior uveitis and diabetes was well described. The severity of the inflammation can range from mild to severe with fibrous hypopyon, and the cause of this association remain unknown. However, an ischemic process about ocular barrier breakdown and the immunological dysfunction have been proposed as a possible theory. And there was no cell in this case. So I think that we can rule out the etiology. So the PCR may not necessary. And the last is the different diagnosis of the early onset or early adult POAG, which was the most likely to be the cause. As I already mentioned, that she has a very advanced stage of the glaucoma, and the pressure might gradually increase in the intercalated pressure. And at some point that the tubercular medulla cannot tolerate, and it might suddenly rise in the intercalated pressure with the acute on top chronic glaucoma and brought her to the emergency. And as you already know that the pain threshold of the diabetes patient might be higher than in non-diabetic patient. And I'm not sure whether how about her control of the diabetes, and have she already checked up before, and how about the pressure before that? Does she develop like an early glaucoma before that or not? I would also like to add some of like fecal or lens-induced increase of the intercalated pressure because of she already has some degree of the cataract as well. That would my comment on the different diagnoses. So what about Professor Shamira and Virna? What do you think about? Very interesting.
Yes, please, Professor Shamira, please.
Yeah, I agree with everything that Professor Kessara said. I think it's important to rule out diagnoses in a stepwise manner, and ultimately, once you've done that, the most likely thing has to be the correct diagnosis. And I think here it's just likely that it is a late presentation of a primary glaucoma. There's only one thing against it, which is the fact that with the corneal edema, it usually signifies a little bit of an acute rise, at least, so there may have been a slight increase, well, an acute rise in the later stages. We know that's been going on for a long time because the disc is already cupped, but the pressure may not have been going that high until more recently.
Mm-hmm. Okay, so we will conclude this case first, and then we will move for the next case. Okay.
What do you think about the treatment?
Oh, the treatment.
What would be your treatment? Yeah. In this case, it seems that he responds very well with their
medication.
Yeah. Hopefully that she will have a very good compliance. I'm not sure about the compliance. Would you perform the surgery, Shamira or Dr. Virna, about the GDI or the mix or subconjunctival mix, something like that? what would your treatment with the cataract extraction combined or stages, whatever?
I'll leave that to Dr. Yulinda first. Do you want to go and comment?
Yeah, for me, yeah, Virna first, maybe.
Oh, me? I think I have several cases with the one that Professor Shamira told me about the open angle glaucoma with a very high IOP, but it is actually uncommon, but I have seen that in my country, several patients coming with a corneal edema with a very high pressure, but actually it is open angle glaucoma. So it is. I think if we could control with the medication, I will start with medication. But then if it is not controlled with medication, I will start with surgery, maybe early surgery. So it depends on how the patient respond. I think it is. It is with me. Yes, Professor Shamira, what do you think?
Yeah, I think so. I mean, at least one eye is hand movements vision, right? So I think one might deserve a TCP. That's what our usual treatment for these kind of eyes.
The left eye. Yeah, the left eye.
But the other one is salvageable. And I think, we need to chat with the patient some more and check their visual potential in that eye, how much cataract there is, whether we're going to do combined operation or separate, and come to the right conclusion for essentially an only eye patient as well. So lots of discussion necessary.
Yes. Thank you. I think the time is only 1 minute left for the first case, so we will move with the next case. But I have to mention first to anyone in the attendee, if has any question, please key in your questions in the chat box found in the bottom of the screen. All the case presenters and mentors will participate in the question and answer session scheduled at the end of this webinar. Now I will introduce with the second case presenter. Is Dr. Sonie Umbara. Is an ophthalmologist in glaucoma division at National Eye Center Cicendo Eye Hospital, and also an academic staff of Faculty of Medicine Padjadjaran University Bandung. He received his medical degree in 2012 and residency program in ophthalmology in 2019 from Padjadjaran University. He then completed glaucoma fellowship at National Eye Center Cicendo Eye Hospital in 2020. He is a member of Indonesian Glaucoma Society, Indonesian Society of Cataract and Refractive Surgery. He is also actively involved in West Java Indonesian Ophthalmology Association activities. And Dr. Umbara, you may now begin your presentation.
Thank you, Dr. Virna, for your kind introduction. Good evening, everyone. First, I would like to thank to APGS committee for giving me this opportunity. Today, I would like to present a case about acetazolamide induced secondary angle cluster glaucoma. The patient was a female, 36 years old, came with the chief complaint of intermittent blurred vision of the left eye. The other symptom was headache, red eye, watery eye, halo. There was no nausea or vomiting. The patient had the same symptoms about a year ago, and the other history was insignificant. Prior to the admission, the patient was using timolol brenzolamide eye drop, and there was no history of using any other medication before. This is the case timeline for the patient. The patient has the same history about a year ago, and on October 15, the patient came to Cicendo Eye Hospital and was treated with timolol maleate and acetazolamide per orally. This is the examination on October 15. We can see on the left eye, the visual acuity was slightly decreased, 20 per 25, and the IOP was 30 millimeter mercury. The anterior chamber was deep on both eyes. And on the posterior examination, we can see the CD ratio is enlarged 0.7. And there was no other findings on the posterior examination. The gonioscopic examination was widely open in both eyes. First, we diagnosed the patient with secondary open-angle glaucoma. We suspected Posner-Schlossman syndrome due to the unilateral nature, and there was no signs of uveitic glaucoma. And we diagnosed different diagnosis with pigmentary glaucoma and maybe asymmetric juvenile open-angle glaucoma. We managed the patient with timolol maleate eye drop and acetazolamide three times a day. And we plan the left eye for trabeculectomy. But 5 days later, the patient came to emergency department, and the chief complaint was pain in both eyes since 6 hours prior to admission, blurry vision, watery, and there was nausea and vomiting. The visual acuity on both eyes decreased to 2 meters finger counting, and the IOP increased to more than 40 millimeter mercury in both eyes. The cornea was edema, and the anterior chamber became shallow, Van Hayek grade 1 in both eyes, and the lens seems anteriorly displaced in both eyes. With the doctors in emergency room, they diagnosed this patient with bilateral acute angle closure and managed the patient with thymol maleate eye drop, continue acetazolamide and oral glycerol 50% 1 times daily, and the patient was planned to control to glaucoma unit. On October 22nd, the patient came to glaucoma unit. The visual acuity was slightly increased to 3 meters finger counting, and the IOP decreased to 20 in the right eye and 24 millimeter mercury in the left eye. The cornea edema seems resolved, but and the anterior chamber still in Van Hayek grade 1, and the lens still anteriorly displaced, and the complaint was reduced. In gonioscopic examination, in both eyes the angle was closed, and we did the gonioscopic indentation gonioscopy, and the angle is open. We diagnosed the patient with suspected acetazolamide induced secondary angle closure glaucoma in both eyes and suspected Posner-Schlossman syndrome in the left eye. We managed the patient. We challenged the diagnosis by stopping acetazolamide, and we give thymol maleate. We give the brinzolamide eye drop, and in the left eye we still plan in trabeculectomy. And approximately 1 week later, the patient came, and the condition resolved with the improvement of visual acuity to 20/25. The IOP decreased to 10 millimeter mercury. The cornea was clear, and the interchamber deep, and the lens is clear and not displaced. The same result in the left eye. And in this the gonioscopic examination in the patient, we can see widely open angle. And this is the fundus examination. We can see the CD ratio is enlarged and with normal fundus, normal other fundus. And the OCT, we can see the thinning of the superior and inferior RNFL quadrant in the left eye and markedly visual field defect in the left eye. We diagnosed the patient with acetazolamide induced secondary angle closure glaucoma in both eyes and suspected Posner-Schlossman syndrome, and we continue the management. As conclusion, bilateral acute angle closure is rare, and some medications can cause this condition. Drug-induced acute angle closure can be sight-threatening if not identified and treated properly, and the clinical findings include high IOP, myopic shift, bilateral acute angle closure, anterior rotation of the lens iris diaphragm, and resolution with deepening of the AC if the medication is withdrawn. UBM can show choroidal effusion. Thank you for your attention.
Thank you, Dr. Umbara, with your nice presentation. And maybe now I invite Professor Shamira first to have their insight, and then the next will Professor Kessara. Please, okay. Professor Shamira.
Thank you very much. That's a great case, Dr. Sonie Umbara, and it highlights, several things. I think that the first thing is that whenever you see a bilateral angle closure, you must think about systemic causes. There are several medications that can cause an acute attack. But this is by an idiosyncratic mechanism. It's not by a sympathomimetic. It's not by a anticholinergic mechanism either. It's simply by this idiosyncratic effect that can occur with several drugs. I mean, the most famous one is topiramate, and that's the one that we all know about. But there are other diseases as well that can cause this uveal effusions. Now, you don't have a UBM, but when you do see the UBMs of these patients, you can have a ranging uveal effusion from something like even just a small slit to something like quite a large amount of fluid that has built up in that circumciliary region to basically push the iris forwards and then close off the angle. And typically, when you see these eyes, you can recognize that it's a uveal effusion type condition, and usually it's medically induced because it's on both eyes. There are some cases, for example, we know that VKH, even CRVO, choroiditis, scleritis can cause it when it's unilateral. But here it's bilateral, so it's obviously a drug-induced mechanism, and it's well known to occur with acetazolamide as well. There are other drugs that can cause it via this idiosyncratic mechanism. Topiramate is the most common, but other sulfur drugs as well, sulfur methoxazole and trimethoprim are also known to cause this. So I think that's a great example of one of the things that we have to be careful of. But the question remains, what was the original diagnosis? Why was the pressure high to 30 in the eye before all this happened? So that one, when there wasn't much signs, I think it's quite fair to assume that it was something like a PSS syndrome in the right age group and unilateral, that kind of fits in. Would you be going towards doing a TAP for that eye? Just a quick question.
Do you want to do the TAP, Dr. Sonie? Yeah, AC TAP, Dr. Sonie.
No, we didn't have the plan to do the TAP because it's rarely done in our hospital.
Sure. But if you're going for the trabeculectomy, you might as well take some fluid off at the same time, and you can always send, because it behaves differently.
Okay.
Yes.
Okay.
Okay. Thank you.
Thank you.
You may
Yes, Prof. Kessara.
KP, yes, you may. I think you may tell from the KPs that KP keratic precipitate. Is there like a stellate KP or just the pigmented one? I'm not sure about this case. Is or can you see anything like a transillumination, like anisotrophy, something like that that may help you, even though you don't have the PCR that's rarely done, but sometimes you can see from the details of the KPs that another line endothelial lesion or anisotrophy, something like that, might help for the differential diagnosis or herpetic or Prosnell-Schwarzman syndrome.
Yeah. Do you see that, Dr. Sonie, in your case?
On the first admission, we only seen a little bit iris pigment, but no KP in the endothelial. But in the gonioscopy on the left eye, we can see the more profound pigmentation of the trabecular meshwork.
Any history of trauma?
No history of trauma, no history of medication, and the patient previously has the same symptom 1 year prior. But yes, when come to our hospital, the CD ratio was enlarged, have enlarged, and that's the examination result as we seen in the previous slide.
Okay. Is there any other?
No transillumination defect, and actually we also have a difficulty diagnosing in the first
the left eye. When the patient came.
Yes, when the patient came.
Yeah. Okay.
In the past, we've done UBMs on these patients to see the size of the effusion and monitor what happens to it over the next few weeks. Typically, it takes about 2 weeks for the effusion to go away.
Okay.
At that time, we didn't have the UBM, and the patient was also have no insurance, because in our hospital, the more examination is quite expensive. So the patient refused to do so.
Okay. So I think it will end our discussion for this case. We will move for the next case, but beforehand, I want to mention to all the participants that we could have our Q&A session in the end of this webinars. So please, if you want to write down in the chat box, please write it down, or maybe later on you could raise your hand. Okay, now I will introduce for the third case. Please, Dr. Yulinda Laksmita, to present your third case.
Good evening and Assalamualaikum. Thank you for the time for me presenting the second case in the scope of glaucoma medical management. A woman 65 years old consulted from the cornea and refractive surgery clinic due to a narrow angle for further management. Patient had undergone the lens extraction on the left eye 1 month prior. No history of eye redness or pain on both eyes, and both of patient's eyes were hyperopic and she used +4 glasses, approximately +5 on both eyes before the lens extraction. The visual acuity of the right eye was 6/6 with correction of +5. The left eye was 6/6 with only minimal correction. She was already in use of timolol eye drops for both eyes, and the IOP was 22 on the right eye and 20 on the left. The AC was quite narrow on the right eye with VH2 and deep on the left eye with VH4. There was a lens haziness on the right eye, while the left eye has already pseudophakic. The cup to this ratio was about 0.4, 0.5 on the right eye and 0.3 on the left eye. Patient was diagnosed with PAC with differential diagnosis of PACG on the right eye and the PAC on the left eye. Also cataract on the right eye and pseudophakic eye on the left. Unfortunately, I cannot get the data of the gonioscopy from 2016. The patient was planned to undergo phaco of the right eye, and the timolol was changed to the fixed combination of travoprost timolol for both eyes. The surgery was done not so long after. After use of travoprost timolol, but before the surgery, the IOP improved to 20 on the right and 15 on the left. After the phaco, as expected, the IOP of the right eye showed further improvement. 18 on the right eye 1 day after the surgery with use of timolol, and 17 1 month after the surgery with use of timolol also. The surgeon omit the use of travoprost right after the surgery in consideration of minimizing risk of post-op macular edema with use of prostaglandin analog. The IOP of the left eye was stable at 14. Starting a month after surgery, patient got the travoprost timolol in fixed combination for both eyes. Patient then had her glaucoma controlled in other hospital for about 2 years, so I cannot show you the data from the 2016 to 2018. But the patient then came again to our center in 2019 already with the use of travoprost timolol and brinzolamide on both eyes. This IOP chart seems quite crowded, but we will get through this slowly from the left to the right. Patient first came again in 2019 with the use of with the IOP of 18 on the right eye and 16 on the left eye with the use of 3 active agents. The medication was then continued. However, 9 months after, she came without the use of travoprost timolol for the last 2 weeks because she ran out of the drop, and the IOP raised on both eyes, 20 on the right eye and 18 on the left. She then again get the travoprost timolol and brinzolamide. In the next visit, the IOP was 18 on both eyes. The travoprost was then changed to the latanoprost to aim a lower pressure for the patient, and it gave a good result. As we can see, the IOP went down to about 16 on the right eye and 14 on the left eye. However, 2 years later, the IOP raised to 23 on the right eye and 21 on the left with routine use of the previous meds. Due to this IOP raise, she got the brinzolamide brimonidine fixed combination instead of the brinzolamide only. The IOP showed improvement in the next visit. However, 4 months after, patient came with complaint of eye redness. She feels that the red eyes occur when using the brinzolamide brimonidine. The IOP was 22 on the right and 20 on the left, and the treatment was changed. She got the tafluprost timolol instead of latanoprost timolol, and also brinzolamide instead of brinzolamide brimonidine. The IOP was then lowered to about 17 to 18. These are the most recent posterior OCT result, where the RNFL of the right eye showed a borderline thinning on the superior quadrant, while the RNFL on the left eye seems good in all sectors. Meanwhile, in the macular GCIPL analysis showed a borderline thinning in both eyes. These are the most recent visual field result, which is from 6 months ago, showing a possible nasal stud defect on the right eye. However, the test reliability for the left eye was not quite good due to a high fixation loss. I hope this long case with a dynamic medical management could be our trigger of discussion that covers some dilemmas such as what to do when the IOP is not on target, is switching among prostaglandin analog classes worth to try, how low the target IOP should be, and also when to consider surgery in this kind of case. Again, thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Yulinda Laksmita, with a nice presentation. And now I invite Professor Kessara and Professor Shamira to give their insight. Please.
Yes. Thank you for the nice case again, Yulinda, and the presentation. This patient had the early stage of the PACG, and with the normal CCT and the borderline IOP, treating with 3 to 4 medication, right? And 1 or 2 bottle after cataract surgery. So it's like a quite maximum than the borderline in IOP. I'm not sure that about the fluctuation of the intraocular pressure. I'm not sure because when you're using the prostaglandin, especially with the travoprost, some kind of prostaglandin, it might develop taps. And this PAP is very difficult to perform the apprenation tonometer. And so I'm not sure whether she developed some kind of this problem or not. And the second one is that when you have like a cataract surgery already, in the case with the cataract surgery already, I think corneoscopy will help to identify is there any PS left or is there any like a parietal iris or just an open angle? Is there like a combined mechanism or mixed mechanism? So we will know what to do further because this kind of problem we will have to identify first. And regarding to the question about the how low that enough and what to do, so it depends. As I mentioned, if it's still or the ankle is fully open, I would consider to perform the SLT. Maybe it helped to stabilize the pressure, not like that's true, and maybe help to reduce the number of the medication. In terms of the switching among the prostaglandin, I think it's pretty low. We don't need to add it. We maybe switch among class. I think the different response to the medication is different among the prostaglandin. So that will be my comment. So I would like to have the corneoscopy right now, and then maybe I'm not sure about the PAPs that might develop before that can cause the fluctuation of the intraocular pressure measurement. How about anyone?
Yeah, thanks a lot, Prof. Kessara. I think that's a good summary of how we should approach the patient, and specifically from the gonioscopy side. You know, how much PAS would get you concerned, Dr. Yulinda?
Yeah.
Unfortunately, I cannot get the gonioscopy result from this patient, so the lack of the report is I also cannot have the data of the gonioscopy. So I think that's really important actually, as you mentioned, that to consider what to do next by the extension of the PAS. Yeah, but
yes. So I think that, you know, gonioscopy is one of the few skills that we can do as glaucomatologists that distinguish us from the rest of the ophthalmologists. And after a while, I mean, I think it gets really fun to do. I love doing gonioscopy. And it tells a lot of information. It really does. And I think anything over 90 degrees of PS you would count as significant, especially if it's recent. In other words, within the last 6 months, it is remediable. In other words, you can do something about it. Yeah. Now, for this particular patient, when you have got this kind of these high pressure despite this medication, you can see that it may be worthwhile changing the prostaglandin. I don't know how you guys feel about the different strengths of the prostaglandins that we use. I mean, but generally speaking, it is considered that something like Ganfort may be a bit more efficacious than some of the other ones that you use. So that's one option. SLT is useful, like Dr. Kessara was saying, but only if the angle's open, after. And so that's quite a key point. And remember, we've done studies on this already, which show that, even if you have 180 degrees residually open after the LPI, it may be worthwhile doing compared to drops. There is a avant-garde treatment. I don't know if you heard about this, something called direct SLT, which is you apply the SLT to the outside, to the sclerotic limbus. But this is investigation only. But there are machines out there now that can apply the laser to the limbus from the outside, so you don't even have to see the angle with SLT to improve the situation. But yes, you're talking about surgery for this patient, and I think it will probably end up as a surgical case. How about you, Dr. Virna?
Okay, thank you. Yes, I think this case is actually with angle closer glaucoma. So I thought maybe if the patient has already have the phacoemulsification, and then we know that the IOP is not well controlled with the medication, I will think actually about doing the surgery. But if I don't have too many I mean I don't have experience with the SLT, but I think we will try to do it, whether it will improve or decrease the IOP or not. But sometimes I thought about if the indication with angle closer and then the patient is not well controlled with medication, usually in our institution we will do the trabeculectomy to the patient. Do you always do that, or maybe something, because the IOP thing with 3 medication only like around 18 or even sometimes 20. What do you think, Prof. Kessara or Prof. Shamira?
Yeah, maybe, yeah, okay. I think it depends also, as I already mentioned, that it depends on the angle. If there is a lot of PS, I would say that the trabeculectomy or even this GDI, but this kind of patient is still in a very early stage of the disease. So target pressure, I would say that for me, I will be high teen, mid-teen, something like that. And so it depends. And if the patient have, after cataract surgery and the angle is open enough, there is some area that we can perform the SLT. I might try SLT first, but I'm not sure about the GSL. Because as I already mentioned, it depends on the gonioscopic finding. I'm not sure where to go, but if there is some kind of the PS and then maybe GSL, and some people, they perform the GAT, right, Professor Shamira, that sometimes they can combine GSL with a GAT to, in this case, because she is a pseudo-fake patient, or even subconjugal mix before we going to the trabeculectomy. But it depends on that is you available on this kind of mix or not, and the affordability or your comfort with this kind of surgery or not.
I think problem in our country is actually affordability, because mix is quite expensive. I don't, in Singapore or maybe in it is
maybe
not that
different.
No problem. But in Jakarta, in Indonesia, I mean, mix is quite expensive. And then also with Ganfort that mentioned by Professor Shamira, it is not available in Indonesia. So we only
Oh, okay.
That's why.
But a lot of PAPs,
Yeah, I know. Okay.
It's available here, but it's very severe PAP. You can tell.
So I think we will end our third case discussion. We will go through with the Q&A session, if it is okay with all of you. So I invite also Dr. Sonie, and I will try to maybe there is a chat box here, and also if participants want to ask, feel free to raise your hand, and then you could just speak directly to us. So I will maybe read one question here that hasn't been, I mean, the first one is about the acetazolamide. I think the Professor Shamira already answered that, right? With the acetazolamide, the causes of the bilateral angle closure due to the uveal effusion in the case with patient with acetazolamide. And then the next one is actually there's Dr. Dai Nguyen asking, do you use atropine for myopic shift in drug-induced glaucoma? What do you think, Professor Kessara or Professor Shamira?
Okay, so there's a simple rule when you're looking at levels of block. Okay, so when the level of block is above the iris, you constrict. So plateau iris, pupil block, you give pilocarpine. Where the level of block is behind the iris, for example, lenticular induced or retrolental, in other words, like things like malignant glaucoma, then you give atropine. So that's the blanket rule. But of course,
Yes.
actually, I mean, the real treatment is getting rid of the inciting agent, which is the acetazolamide.
Yeah.
Yes. Professor Kessara, do you have any comment?
I agree. It's going to be getting worse if it is from the cerebral block. This is the contraindication for the pilocarpine. But but you need to know that not only if it is, as Dr. Shamila said, that some people, I think more common will be acute ankle closure with pupillary block attack with the like antihistamine or over-the-counter drug, because in those kind of the occludable angle. But in case, so you need to identify very well. You need to separate very well. Is it going to be from the pupillary block or cerebral block? Because the management is on the contrary. If you're doing it wrong, it's going to be getting very worse. So you need to identify very well, is this a pupillary block or non-pupillary block? That's all.
I think for the choroidal effusion, we didn't use atropine, right? Only malignant glaucoma, if there is like a ciliary rotation of the anterior ciliary anterior rotation of the ciliary body, right? Then we will, maybe atropine will work, but for the choroidal effusion, I think it will not work, right, Professor Shamira? It depends on the mechanism, right? If it is like
yeah, so for lens induced, so for things like phacoemorphic sublux lenses, it also works. You know, you dilate the people, you atropinize, and that will help the situation. But realistically, it's a drug-induced situation. It will not.
It will not work. Yeah, it will not work. Okay. And then there is also a question with whether is there any possibility that the case in the first case with Dr. Yulinda Laksmita, whether it is probably Posner-Schlossman syndrome case? What do you think?
As I already mentioned, that it's come with the bilateral involvement, which is quite unusual simultaneously. And when you look at the cup, this ratio is very advanced. So normally in the Posner-Schlossman syndrome, except that patient has previous history of intermittent attack and they didn't come to the hospital and the pressure just rise up, something like that. But you can tell that they might have something like a KPs, but it can be, but very unlikely, as I already mentioned, that came at the both only simultaneously, and the angle, there are no KP or AC cells, which is quite unlikely.
Okay. Professor Shamira, do you have a comment?
What do you think?
Posner-Schlossman is very typically unilateral. Yeah, so I mean, that's the thing that's against that. And they present quite early. They recognize that they get blurring of vision, not so much pain, but blurring of vision happens early. And with very high pressures, you're right, they get to pressures above 50 sometimes, yeah. But I think common things are common. I think we just have to assume that this is a very late presentation of a primary open angle glaucoma.
Okay. And then there is also a question for the next case, the second case by Dr. Sonie. Do you suggest the surgery for this kind of case? I mean, after you know that the left eye already like high IOP prior the occurrence of the acetazolamide incidents, right? Then afterward, actually the IOP, although it is decreased, but still some kind of increase in the left eye. What do you think about it? whether we should suggest the surgery in this case or not? Professor Shamira?
So I think for that particular case, I mean, there's a lot going on. So I think if we exclude the drug-induced choroidal effusion problem, which is resolved now, we need to look at the basics. There is something going on in that left eye, and I think we have to judge that on its own merits. Look at the progression, look at the IOP, patient's age, and take those factors into account, and consider for operation as an independent variable to that episode of the acute attack, which was drug-induced. We should also warn the patient about use of other drugs that are sulfur agents as well that may cause this to occur again.
Okay.
Yeah. I think the second case might be more likely to be Posner-Schwarzman syndrome, and because of the unilateral, and then the patient can with the intermittent attack. So there might be the possibility, if it is the Posner-Schwarzman syndrome, I think giving the antiviral agent, even either the systemic or the topical antiviral agent, sometimes it can give a very better control at intraocular pressure, and they can prevent attack as well. So we maybe postpone or delay the surgery. But if it depends on the diagnosis. If it is the pigmentary dispersion, I think this kind of disease can respond very well with the SLT. So maybe SLT will be a better choice, because this patient is still young, and if you are going to perform the trabeculectomy, they also have the risk of the surgery failure. So we need to we try to do so, but we have to wait between the risk of failure and then also the gain that we are going to get from the trabeculectomy. One more thing that I would like to see is that she also have a little bit of advanced threatening to the fixation. So I would like to have the visual field of the 10-2 visual field to see if anything that developed to threaten to the macular and macular area or not, and the cross follow-up.
Okay, Dr. Sonie, has you already follow up this patient?
Yes.
The second case?
Actually, no, the patient didn't come again. But after we diagnosed with acetazolamide, the patient was treated with trabeculectomy in the left eye. And in months after the surgery, the patient didn't come again to our hospital. So no, we didn't see the patient again.
Okay. Okay then. Now for and now for the last for the third case, there is also a question. Do you think it is necessary to stop the prostaglandin analog drop during phaco in perioperative period? Do you have any comment, Professor Shamira or Professor Kessara, regarding the use of prostaglandin analog after we did phaco? Is there any occurrence of cystoid macular edema on your patients, or maybe it is just like just our fright for giving so?
So I would say if there's a complication during the surgery that would render the patient aphakic, that you couldn't put lens in, for example, then I think I would be cautious about giving prostaglandins. But I think otherwise, we use it so often, and there's not really much problems. I mean, CMO is an issue with some drugs, agreed, but I think we usually wait to see what happens because it's such a useful adjunct for our treatment.
Okay. How is Professor Kessara? Do you have any experience?
Because I'm the uveitis specialist and also the uveitis specialist, and I've seen a lot of the cystoid macular edema from the uveitis, so I didn't scare at all. And but I think in my experience, I don't think that it's necessary to stop the prostaglandin before and after cataract surgery for me. I didn't stop.
Sure.
Stop.
There's just one indication. So, for example, if you have a patient on Ibelis, I don't know if that's available in various countries. Right? So it's actually considered a contraindication to use it in case of pseudophakia. So it gives an awkward situation where we have a patient who's on Ibelis preoperatively, but we cannot continue the Ibelis after they've been made pseudophakic.
Yeah, I agree with Professor Shamira. Not because I'm afraid of the eye list, but I just afraid that they label in its leaflet that you cannot use in the pseudophakic patient, or else you're going to be sued. Because in the US, I think they didn't put this kind of contraindication in that leaflet, But in Asia, they put this kind of contraindication. So I will switch to another prostaglandin if it is necessary.
Yeah, that's right. So they had an option, because they did see some CMO in
the
eyes, but they worded it very strongly as a contraindication. So you'd be using it against, medical advice if you were going to be doing it in that situation. They could have made it milder, they could have made it, softer, but they actually put it as a contraindication.
Contraindication, not relatively, absolute contraindication. So you need to be very careful about this.
Okay, but not with other prostaglandin, only the IVs. Okay, thank you so much. I think we almost in the end of our session, and I don't think there is anybody has raising their hand. So I thank so much with Professor Shamira, Professor Kessara, Dr. Yulinda Laksmita and Dr. Sonie Umbara with a very, very nice presentation and case discussion. It is very fruitful experience for me as well. A big thank you to all our attendees today. And then we will have that all of you could join us also in the next Young Glaucoma Expert webinars. Please, as mentioned earlier, you will receive a short survey to provide your feedback on this event. Your participation will help us improve on future professional development offerings. So please fill in our survey. APGS also has a YouTube channel, and we invite you to subscribe so you can be updated on our latest content. So this concludes the Asia Pacific Glaucoma Society Young Glaucoma Expert Program for May. Have a wonderful day or evening, depending on where you are. And you may now disconnect. Thank you so much with all the participation. And nice to meet you. And also, hopefully, we could meet you all on July. Bye-bye.
Thank you. Bye-bye.
Bye-bye.